the UK, internationally. I know because our show is really popular with many of you, and it's an absolute delight to come back each week and give you these shows that tell you about the latest updates in health and to give you relevant information that's pertinent to your health, as well as giving you bits and pieces of services that can signpost you to relevant information regarding medical matters that are relevant to you. So we are airing on Inspire FM 105.1 in Luton, and we're also airing on Salaam Radio 106.2 FM. I want you to participate in the show. Of course I do. I want you to participate in the show and tell me how you feel about it. I've already got some questions that have come through, and I'm absolutely delighted to introduce my guest, who I will be telling you a little bit about in a short while. But I thought, why don't we bring on guests that are very well versed in their fields? And this is a particular doctor who I saw making his own videos on YouTube and trying to educate the masses, actually. So let me introduce you to Mr Khalid Qureshi, who is a vascular surgeon at the Doncaster Royal Infirmary. Assalamu alaikum, Mr Qureshi.
Walaikum salam, Dr. Shabina. Thank you very much for inviting me to your show.
Not a problem at all. So I actually had a look at the talks that you were giving, and I thought, this is wonderful. Why don't we spread this out to the masses?
Okay, thank you for that.
Yeah, not a problem at all. So if you'd like to join into the show, it'd be wonderful if you could text and WhatsApp us on 07745278978. Get your questions on board. We want you to participate. You can certainly phone us on the studio telephone number with the Peterborough telephone code of 01733 602 133, and you can watch us on Facebook Live, YouTube Live, and Twitter Live as well. I know because I share the show on Twitter Live too, which gets a lot of positive response, which is brilliant. I hope you're all okay, well this evening. You've all eaten dinner, especially you little ones. Must be getting tired with the term has settled in and you're all back to school. And I know a lot of you, through my own patients, come to see me because the weather's just recently changed. So keep warm, make sure that you keep up nicely wrapped and warm, and that you're taking care of your health in the best possible way. So coming back, Mr Qureshi, I'd like to ask you first of all, could you tell our guests and share with our guests what inspired you to go into the specialism of vascular surgery, please?
Okay. First of all, ever since I was at medical school, I was intrigued by surgery. I really loved it. Okay. I loved operating on people, and I thought I would like to go into a specialty where there is a lot of finesse involved and something which is quite challenging. Vascular surgery at that time when I was at medical school was still part of general surgery, so it was general and vascular surgery. Right. However, over the past few years, it has now become a separate specialty.
Yes.
And it's just the finesse, the fact that we do anastomosis in millimeters, arteries are very, very small that we operate on.
Yeah.
It's quite a challenging specialty, but at the same time, it can be very rewarding. And it's vascular problem is one of those things which is very widespread. I mean, the risk factors are everywhere. Lots of people have vascular disease. So it's just one of those things I was very interested ever since I first saw it, to be honest. And I thought, okay, this is something which I'll see if I can do and see if I like. And I just really enjoyed it.
Yeah, well, that sounds really good. And I must say that from a vascular surgery perspective, I previously had a background of surgery as well before I went into general practice. And there is nothing that causes palpitations more than hitting a major vessel or a vessel and then trying to stem it from bleeding. So I completely, actually, hats off to you and kudos to you that you have gone into a speciality that actually is very intriguing, very interesting. And yes, it can be one that's quite, but puts the pressure on, if I'm able to say so in the most reserved of terminologies. Now, we're talking a little bit about, Mr. Qureshi, a little bit about peripheral vascular disease. And a lot of our shows are sort of quite simplified in language. Would you like to explain to our listeners, please, what peripheral vascular disease is?
Yeah. Okay. Before I actually go into what peripheral vascular disease is, I just wanted to clarify one thing which I've seen people getting confused about quite a lot.
Sure.
Very simple terms in medical terms, but people get confused. One thing is an artery, another thing is a vein.
Okay.
Now, we need to understand that arteries are those blood vessels that take blood away from the heart to the rest of the body.
Yeah.
And veins are those blood vessels that bring blood back from the body to the heart. And the reason I thought I'd clarify this is because I've seen many patients come in who use the terms arteries and veins interchangeably. They think they've got a problem with their veins when it's actually their arteries.
Yeah.
So these two blood vessels are totally different things. Artery takes blood away from the heart and veins bring blood back towards the heart.
Okay.
Peripheral vascular disease is a disease of the arteries. So in other words, the blood vessels that take blood away from the heart. As the name signifies, it's peripheral. By peripheral, it means in the arms or the legs, away from the trunk of the body.
Okay.
So peripheral vascular disease is a disease of those blood vessels that happens in the arteries, in simpler terms, in the arms or the legs. Most commonly the legs, though.
Okay.
Now, in peripheral vascular disease, what actually happens is the artery itself is narrow, or gets narrowed, or gets blocked.
Okay.
Therefore, the blood, which is supposed to travel through the arteries and get to wherever it needs to go, doesn't get there. Or if it does get there, it doesn't get there in the right amount.
Right.
And it's essentially what peripheral vascular disease is. The reason you have the obstruction in the blood vessel or a narrowing in the blood vessel is because of a condition called atherosclerosis, which is essentially building up of calcium or fats and narrowing the blood vessel.
Sure.
That is, in very simple terms, what peripheral vascular disease involves: blood not getting to the places where it is supposed to go. And the problem that causes is that blood carries oxygen and all other nutrition that is needed by the muscles or other parts of the body. So if blood is not getting to one particular place, that particular part of the body is not receiving the oxygen and the nutrition that it needs.
Okay.
Therefore, it suffers.
Okay.
And that's why people with peripheral vascular disease get the symptoms due to lack of blood, lack of oxygen, lack of nutrition to that particular part of the body.
Okay. And so that's actually quite straightforward, because we're able to explain to, you've very eloquently explained to our listeners that it's a disease of the end vessels, namely the arteries, that provide blood supply to the ends of the body, such as your arms, your hands, feet, legs, etc. So coming on from that, atherosclerosis, blockage of the artery with cholesterol, would you say? What would be the causes of peripheral arterial disease?
Okay. Now, peripheral arterial disease, there are certain risk factors which predispose an individual to this problem. So that's the main reason why people get it. We can say there are 5 main risk factors which are responsible for the development of peripheral vascular disease.
Right.
First risk factor is diabetes. Patients who have diabetes are at a higher risk of getting peripheral vascular disease. Therefore, control of diabetes is very important.
Right.
The next risk factor is hypercholesterolemia or high cholesterol.
Okay.
That is a very important risk factor. Controlling that also helps protect against peripheral vascular disease.
Okay.
Third risk factor, smoking. Very, very important. Smoking accelerates the risk of peripheral vascular disease very much. So that, again, is a risk factor. And the fourth risk factor is hypertension or high blood pressure. Okay. So if the blood pressure isn't controlled, then that also predisposes to peripheral vascular disease. These 4 risk factors are called modifiable risk factors because these are things which can be controlled.
Sure.
And there is a fifth risk factor which we can't do anything about, and that's family history and genetics. If you have a family history of peripheral vascular disease, that automatically puts you into the group of people who are more prone to it.
Yeah.
But unfortunately, you can't do anything about that. However, the other four risk factors can be controlled, and the disease progression can be controlled to an extent.
Right. Okay. So it's really quite sort of pertinent, and I hope that all of my diabetic listeners are listening, because we've got a high prevalence of diabetes here within Peterborough especially, and because we have a large Southeast Asian demographic residing here within Peterborough as well as in Luton. And it's very important for these listeners to listen and understand what these risk factors are, and the importance of regulating things like their blood sugar and their blood pressure, the importance of taking their medication. So I hope you're all listening out there, because this is very, very important. Now, as Mr. Qureshi continues to tell us a little bit more about what involves peripheral vascular disease and how it's sort of diagnosed and what symptoms we expect, you will understand how important it is to look after yourself in the way of risk factors, like Mr. Qureshi has explained. So following on from that, Mr. Qureshi, would you like to tell the listeners a little bit about what symptoms they could expect if they were sort of suffering from peripheral vascular disease?
Yeah. Now, when an individual starts to develop peripheral vascular disease, now, to keep it simple, I'll just talk about the lower limbs or the legs, because that's where it's more common.
Sure.
But equally, same thing can happen in the arms as well, but legs are more common, so I'll stick to that example.
Sure.
In the initial stages, people say that they can walk for a certain distance, and then suddenly their muscles seize up. They just freeze. They can't move.
Okay.
So they stay still for a minute or two, and then they can walk the same distance again. This is very, very typical of peripheral vascular disease, and in medical terms, it's called intermittent claudication.
Okay.
The reason this happens is, again, as I explained, because of not enough oxygen getting there. Whenever we are walking, we are using the muscles of our leg.
Yeah.
So they need extra oxygen to cope with walking. A normal, healthy person doesn't even realize it. But when the blood flow is already compromised, there's not enough blood getting to the muscles, when an individual starts walking, the diseased arteries cannot cope up with the demand to provide more blood because they're so narrow. So not enough blood gets to the muscle. The muscle starts to hurt. They get pain in the muscles, and they have to stop walking. They just can't walk. Now, in this problem, this place where you get the pain depends upon where the disease is.
Right.
For example, the most common place for this disease to occur is in the artery of the thigh, which we call the superficial femoral artery in clinical terms.
Okay.
So if there is a blockage or a narrowing in the thigh, then the muscles beyond the thigh will be deprived of oxygen when you walk, and therefore these patients get pain in the calf when they're walking. Similarly, if there's an artery in the tummy that can be blocked, the iliacs, then they get pain in the buttocks. So it's usually the muscles below the artery, that's where you get the pain, and that's intermittent claudication. This is how disease starts. Now, initially people say that, okay, they can walk a few hundred yards and then they have to stop, then they can walk the same distance again, then they have to walk. In some patients, it stays stable. In others, it progresses.
Okay.
So they can then say, oh, we're getting pain at a lesser distance now. We're not walking as far as we were walking. And you can see a gradual deterioration in their symptoms. And that is progression of intermittent claudication.
Okay.
If the blood supply in peripheral vascular disease gets even worse, then people can get pain even without walking.
Sure.
They're at night time when they're sleeping, they get pain in their feet or their legs because now the blood flow is so poor that they can't even cope with the supply that the demands, or they can't even cope at rest. That's progression of disease. Then as it goes even worse, people start getting ulcerations.
Yeah.
And ulcerations, I mean, skin breaks down and they get infections and so on and so forth. So intermittent claudication is an early sign. However, it can progress to ulcers, rest pain, and other symptoms which we take as a more serious condition.
Mm-hmm.
That condition, if they develop ulcers or they start getting pain at rest, some people say that they can't sleep in a bed.
Okay.
Because when we're standing,
Yeah.
gravity helps the blood get to our feet and legs.
True.
But when you're lying flat in bed, you've eliminated gravity. So it's only your heart and your blood vessels that's responsible for the blood getting to extremities.
Sure.
And if it's damaged and you've taken away gravity, there's not enough blood getting to the feet. So that's why people start getting pain when they're in bed. So they start sleeping in chairs. And we get patients who haven't slept in a bed for months.
Oh, my goodness.
It's so painful. And they come with horrendous leg swellings and leg ulcers. And it's quite a serious thing. So when it gets to that stage, that's called critical ischemia.
Yeah.
So you're getting pain on walking, that's intermittent claudication.
Yeah.
When it gets to rest pain, which has been on for at least 2 weeks, or if they start getting ulcerations, then that is called critical ischemia.
Yeah.
And if critical ischemia is not treated promptly, more often than not, it results in limb amputation.
Oh, wow.
Very, very important to diagnose it early, do something about it early, and prevent the progression of peripheral vascular disease from intermittent claudication to critical limb ischemia.
Wow. Okay. Now, going back to the intermittent claudication that you were talking about, when one walks and they feel pain, does the pain? So, in order to sort of diagnose intermittent claudication, would one have to feel enough pain upon walking that it makes them stop?
That depends on individuals. Usually people stop because they say the muscle seizes up.
Right.
However, there are certain people, or certain percentage of people, who continue to walk through the pain.
Yeah.
And we recommend that if you are getting the symptoms, try to walk through the pain, because walking through the pain promotes growth of new blood vessels around the blockage.
Fair enough.
Something in clinical terms we call collateralization, or formation of collateral blood vessels.
Okay.
So we can think of it simply as, if you imagine your main blood vessels going down your leg is a motorway for the blood to flow. If that is blocked, but you continue to try walking through the pain, then the body can build smaller roads around the blockage to bypass the blockage and get some more blood down, which will never be as good as the original blood flow, but it's probably enough to get people through. So answering your question, do they always stop? Not always stop. Sometimes they slow down. And people who've had this for a very long time, they can actually judge how far they can walk. So you see people walking around town, they can spot a wall and they know that that's the distance they can walk maximum, and then they have to stop. So they go and walk to the wall and rest against the wall, or they spot a bench and they know that's the only distance they can do. So they try and find objects when they're out and about where they can hold on to and rest when this pain kicks in.
Fair enough. Well, I've just been looking at my video on the computer and seeing how actually worried I'm looking, because the majority of patients that come to me complain of leg pain, and often, you know, as GPs, I think that we don't take it seriously enough because we put it down to probably low vitamin D. Sometimes, especially Asian women, have a lack of ferritin, and a lot of women will come to us and say that they have leg pain. And I'm honestly, it's a reflection just listening to this talk, because I'm thinking back to all my patients and thinking, okay, well, you know, one should ask a little bit more in depth. One should sort of implement in your history that ask your patient, for example, you know, is it painful enough? Do you get it on walking? These are all the relevant questions one needs to ask within a 10-minute consultation. So I think that that's really pertinent that you've put across. Now, I have, say, a woman or a patient that walks through the door and tells me exactly what you've described. My legs keep seizing up. How would we approach this patient, Mr. Qureshi, and how would we then subsequently deal with them?
Okay, so if you have a patient and you have clinically diagnosed with them as having intermittent claudication, you've excluded obviously neurological causes like due to a spinal cause or lots of patients have arthritis, and so you've excluded all those causes, but you now have a patient who has intermittent claudication.
Yeah.
So the first management is control of risk factors.
Sure.
That is the first thing. By that, I mean, make sure hypertension is controlled, make sure diabetes is controlled. They should all be on a statin.
Mm-hmm.
Even if the cholesterol is normal, we get lots of people with normal cholesterol levels, we still put them on a statin because there is enough evidence to say that statins actually prevent inflammation within blood vessels, and it's inflammation which causes progression of peripheral vascular disease. So statins are very important as well.
Okay.
Stopping smoking, very, very important.
Yeah.
It goes. And apart from statins, the other thing would be to start them on an antiplatelet agent like aspirin. Since one dose of aspirin, some people say that they're intolerant to aspirin, so there are other antiplatelet agents around, but an antiplatelet is also recommended as a first-line management. So control those risk factors, and a statin and an antiplatelet is the first line of management.
Okay.
After that, it has been proven that if someone has intermittent claudication, let's say it's been going on for a while, it's about 300, 400, 500 yards, they don't have critical ischemia, then apart from risk factors and antiplatelet and statins, exercise is very, very helpful.
Okay.
When you do exercise, or as exercise I mean walking more or whatever, it'll promote new blood vessel growth around the blockage or collateralization. However, the person will have to try and push themselves beyond what their threshold for claudication is, which isn't very easy because muscle seize up. Therefore, lots of trusts around the country have made supervised exercise groups, where there are groups of people who get together with a fitness instructor or a physiotherapist or someone who's got a bit of knowledge about this, and they do group exercise. And as we all know, that working in a group is obviously more productive than an individual trying it on their own.
Okay.
This facility isn't available in all trusts, I must say, around the country, but there are certain places. So if you do have supervised exercise classes around for claudicants, that would be the best thing to do.
Yeah.
So the things that can be started in the community. However, despite that, they would still need review by a vascular surgeon. And obviously, when they're referred to us and all this has been started, we obviously do the same thing that you've done, take a history, examine them. And then question comes on how to investigate these patients. There are various tests or modalities, as we can call it, to diagnose patients with peripheral vascular disease. And these vary from place to place and from patient to patient. There, you can do an ultrasound scan of the arteries. The advantage of that is that it's a non-invasive test. It doesn't involve an anesthetic. It doesn't involve any radiation. However, looking at the very small arteries below the knee in diabetic patients isn't very easy. You may not get a very good answer. You could do a CT scan, a CT angiogram. But the disadvantage of that is you're giving radiation to a patient, and if the patient already has a kidney problem, the kidneys aren't very good, then you're giving contrast as well to them, which can affect the kidneys. Go for some places do an MR angiogram, so an MRI scan of the arteries. Again, depends upon whether the patient is suitable for that or not. There are some patients who are on the obese side and they can't have a proper MRI. Some people are claustrophobic, they can't go into an MRI machine. Some people have devices or implants which are not suitable for MRI. And the other investigation you could do is an angiogram, which essentially is putting a needle into the groin, putting a wire into the artery, and then taking pictures directly. But that's an invasive test. The advantage of doing an angiogram is that you can potentially treat the condition in the same sitting by doing an angioplasty if needed. However, it's an invasive test. you're giving contrast, which can damage the kidneys, you're exposing them to radiation. Some people do bleed after it, and on occasion have bled a lot. Yeah. And things can go wrong in an invasive test.
Yeah, absolutely.
So it's nothing is 100%, but then looking at a patient, taking a history from the patient, examining the patient will point us into which direction we need to go and what we can do. And the general fitness of a patient is also very important.
Yeah, absolutely.
Because if we have a very elderly patient who's maybe 80, 90 years old, who just goes around the house.
Sorry to interrupt. We're just coming up to a 4-minute break, Mr. Qureshi. Okay. We will join you after the break. Please stay on hold. This is a fascinating program. Join us after the break, people.
Thank you.
Stay tuned to Salaam Radio after this short ad break.
1 in every 10 people live without access to safe, clean water. Let's give them a better choice than drinking either dirty water or no water at all. Together, we can turn this desperate situation around by delivering safe water solutions to the world's poorest people. Call 0161 225 0225 or visit humanappeal.org.uk.
The Lantern Initiative presents Peace of Mind, a screening of short mental health documentaries and talks at the Key Theatre in Peterborough. Hear from Mayera Khan from the Muslim Counsellor and Psychotherapist Network as she talks about cross-cultural conflict, Sunday the 30th of September at the Key Theatre, Embankment Road, Peterborough, 6 to 7:30 p.m. Tickets are only £5 and available via Eventbrite, suitable for all over 16 years of age. For inquiries or for direct bookings, please email The Lantern Initiative at outlook.com or call Sephora Horton on 07 821 574475.
Third world and developing countries are home to some of the most vulnerable children on the planet. Malnutrition, severe lack of medical aid and access to clean water are just some of the horrific challenges faced by orphans across Africa and Asia. Children of Adam, a Peterborough charity, need your help to bring aid to these orphans for just £25 a month. To sponsor an orphan or assist with other projects, please call 0300 321 0032 or visit www.childrenofadam.net.
Need a great place to chill out? Look no further than The Lounge for quality food and drinks at a great price. Try our varied menu: pasta, seafood, burgers, grills, salad, soup, rice and sides. Also hot and cold drinks, milkshakes and mocktails. Leave room for our exquisite desserts. The Lounge, 417 Lincoln Road, Peterborough. Call 01733 709 306 to order for delivery. The Lounge, friendly service with a great atmosphere.
Almirad Tiles. With over 70 stores nationwide, we are now open in Peterborough. Up to 50% discount offers now on. Largest selection of tiles. Full bathroom suites from only £189. Paint, LED lighting, laminate flooring from only £7.99. Over 1,000 designs of wallpaper in stock. We have everything you need. Come and visit us at 193 Fengate, Peterborough, PE1 5BH, or call us on 01733 34 58 47. Almirad Tiles, now open.
Surely your Lord is God, who created the heavens and the earth in 6 days, then sat himself upon the throne, covering the day with the night it pursues urgently, and the sun and the moon and the stars subservient by his command. Verily, his are the creation and the command. Blessed be God, the Lord of all being.
Broadcasting 24 hours a day, 365 days a year. This is Salaam Radio.
Assalamu alaikum and welcome back to your very own Dr. Shabina Asad Qayyum on the one and only Body Health and Mind Show. Yeah, of course I'm going to say one and only. We get brilliant guests that come on board, which is wonderful. We were having such a wonderful conversation with our very special guest, Mr Khalid Qureshi. He's a vascular surgeon at the Doncaster Royal Infirmary. And Mr Khalid Qureshi, you have kept the radio buzzing, I must say, because we have people. We've got 6 viewers watching us. We've got I would like to thank Amber Naqvi for watching us, and we have Mr Ansar Ali, and I want to send some get well wishes soon to my uncle Ansar Ali, who's a presenter here on the radio, and he's undergone major surgeries at Adam Brooks Hospital, and he is in full spirits. He's still on Facebook seeing how we're all doing and making sure we all behave ourselves. But Uncle Ansar Ali, I know, will be back in full force, and we have many of our listeners who have been listening in, and we've got some questions as well, which is brilliant. So I had a question here from a brother or a sister, they haven't told me, Talat, who says, please ask Mr Qureshi, aspirin or no aspirin, even if there is nothing wrong with me?
Okay. Taking a medicine in the absence of a disease is called primary prevention.
Okay.
Now, this is a very, very important question because this is quite a heated debate amongst vascular surgeons at the moment.
I know it is.
Whether to give an aspirin to someone who is otherwise very fit and well, does not have any problem with the blood vessels.
Yeah.
They've not got peripheral vascular disease, and they don't have any risk factors of peripheral vascular disease.
Okay.
Will they benefit? There is no evidence to say that they will benefit.
All right.
Some people do give it. I know they do. But if we're talking about evidence-based medicine, about what's out in the world, what we can follow, till date, there is nothing to say that giving aspirin to somebody who does not have a problem with the blood vessels will prevent them from getting it. It doesn't help.
Okay.
That's the bottom line at the moment.
Okay. So you are in the nay camp.
Kind of, yeah.
Yeah, okay. Well, that's good. It's good that we know, because you're absolutely right. There has been a lot of sort of media hype about, you know, sometimes you have this sort of era whereby they advocate aspirin, and then after a while they're sort of saying, no, we shouldn't be taking aspirin. So it's good to know that. I have another question here from a sister Zara. Thank you very much for your question and listening. She says, may you ask Mr Qureshi, can you advise what gangrene means? My dad has peripheral vascular disease, and he's got some really poor control of his diabetes. He has been told by his surgeon that he could develop gangrene.
Okay. Gangrene essentially means tissue that's non-viable.
Okay.
In simpler terms, dead or dying.
Sure.
Now, gangrene in vascular disease, you can have 2 different kinds of gangrene.
Mm-hmm.
In one condition, the extremity becomes black.
Right.
And that's due to pure lack of blood flow. And that's called dry gangrene. So it's a very common thing. You'll see people with a black toe or black toes.
Yeah.
Or it can progress. That's called dry gangrene.
Mm-hmm.
The other kind of gangrene is what people with diabetes get more commonly, and that's wet gangrene, in which the extremity swells up, starts discharging foul liquid, foul fluid, and essentially it's spreading infection.
Right.
That has to be controlled, otherwise it can spread.
Okay.
So gangrene is dead tissue or dying tissue, and 2 different types. If it's purely vascular with no infection, that's dry gangrene. Otherwise, people get wet gangrene as well.
Okay. Do you do anything about dry gangrene? I'm just asking for my own sake.
If it's dry gangrene itself, then that will depend upon how good the circulation is. If, for example, someone has dry gangrene at the tip of a toe, and the blood flow to the rest of the foot is absolutely fine, you can take that bit of toe off surgically and it'll heal up. However, if the blood flow to the rest of the foot is not very good, and you were to take that area of gangrene off, that wound will never heal, because for wound healing you need blood flow. So what would happen is that comes off, the remaining wound doesn't heal, that becomes gangrenous, then you have to do more and more and more and more, and it can go on for a while. So if it's dry gangrene in someone who's very frail and elderly and not very good blood flow, as long as it's not infected, it alone.
Okay.
And it's a very strange way of saying things, but we tell patients who are very elderly that if it's dry, it's not infected, it'll drop off. I know it sounds strange.
I was going to say.
Nature takes it off.
Okay, so I enjoy that part. That's the part I miss about being in surgery, is the sheer sort of being blunt attitude. It's all right, that's fine. If it doesn't work, we'll take it off, or it'll drop off by itself. But for a patient, it's sort of, ooh, very, very...
It is a bit. But then again, the problem is that if it's dry gangrene and we try doing something heroic and there is not enough blood flow, that little gangrene, which was just on a toe, could mean the patient loses their leg because there's just not enough blood flow. So you have to make a decision based on an individual. But the bottom line is, if it's dry gangrene, don't worry about it. It can be sorted out.
Brilliant.
Wet gangrene is a different issue, needs antibiotics, may need some operation to clean up all the dirty stuff, depending on how bad it is.
Okay, well that's wonderful, because I've got a lot of thumbs up here from Mr. Majid Hussain and Mr. Adil Khan. Thank you very much for giving us that thumbs up and encouragement, which means that people are taking the information on board, which is what we always want. Now, Mr. Qureshi, do we have time to talk about varicose veins?
We have time, yeah, of course. Just before we go on varicose veins, one important thing about peripheral vascular disease, which I must stress upon.
Sure.
Vascular disease, as in arterial disease, is not limited to one artery only. If someone has disease in a part of the body because of a narrowing or a blockage, it does not mean they don't have disease in other arteries of the body. It is a systemic problem. It will be present in other arteries as well. However, it will be more predominant where the disease is more severe.
Right.
And very importantly, people with peripheral vascular disease, a large proportion of these patients, even though they may have never had a heart attack, they will have some disease in their blood vessels going to the heart as well.
Right.
So it's very, very important that people need to be aware of that.
Okay, that's very important. You're absolutely right, which means, listeners, all the time when we keep on stressing about good diabetic control, good control of your blood pressure, see what you're eating, keep on exercising, it is only for your own health. So that's been a fantastic talk about peripheral vascular disease. And indeed, if there are topics that we sort of can't complete, we will definitely would love to have you on again, because this has been a fantastic show. Very, very lively and very, very energetic, because we've got a lot of participation that's come on board. Now, Mr. Qureshi, with regards to varicose veins, I must say this is one bugbear of mine, because as you know, the funding requirements have changed within the NHS with varicose veins.
Okay.
You probably knew where this topic was coming from when I said I wanted to talk about it.
Yeah.
So could we explain to our listeners how varicose veins develop? Everybody knows what varicose veins are, but how do they actually develop?
Okay. Varicose veins, very common condition, and essentially it's dilated veins, which again can happen in any part of the body.
Yeah.
More commonly happens in the legs, lower limbs, so that's what I'll talk about.
Okay.
Now, varicose veins, we can broadly divide them into primary varicose veins and secondary varicose veins.
Okay.
Because if we remember, veins take blood back towards the heart. So therefore, the veins in our legs work against gravity and take blood back towards the heart.
Okay.
So when we are walking now, with varicose veins, we need to remember there are two sets of veins in the leg, superficial veins and deep veins.
Right.
Superficial veins are the veins we can see. Deep veins are the veins inside our muscles.
Yeah.
That's one of the important things about veins. So when blood goes up through a vein, the pressure of the vein is reduced and the blood travels to the heart. However, if the veins are not working properly, the blood doesn't go up and pools in the veins. Now, there could be a number of reasons for that.
Okay.
There are valves in a vein, so that once blood goes up, the blood doesn't drop back down. The valves can get damaged.
Okay.
So therefore, the blood travels up the leg and then falls back down again.
Right.
And as a result, you get increased pooling of blood in the veins. the pressure in the veins increases and the veins get bigger, and that's essentially called varicose veins. So that's primary varicose vein.
Right.
Other people get varicose veins due to another disease or another cause. I wouldn't say disease, but another cause. For example, very common when females are pregnant, quite a lot of them get varicose veins.
Yes.
That's because the uterus presses on the veins in the pelvis, which creates increased pressure on the veins in the legs. They get bigger.
Yeah.
After delivery of the baby, the veins go away.
Okay.
Similarly, tumors in the pelvis can cause it. People who've had DVTs in the past, which is a disease of the deep veins, they get varicose veins as well. So these are secondary varicose veins due to another cause. At the end of the day, the main thing that happens is there's increased blood in the veins, increased pressure, and that's what causes them.
Okay, okay. Well, we've got a Dr. Azhar Chaudhry who's joined us, who says, great talk, concise and to the point. And we also have Miss Humaira Khan, well explained. A Councillor Amjad Iqbal Sahab has just joined us. Thank you very much for your company. We are very privileged to have you on board. And a brother Faz Ali has joined us as well. So thank you. We hope you're all benefiting from this talk, especially those of you who smoke, because after listening to today's talk, I'm more than certain that Mr. Qureshi will convince you to stop smoking, because you might end up having one or two toes that drop off down the line somewhere. So coming back to varicose veins, Mr. Qureshi, we've spoken about it, spoken about risk factors. Now, you've eloquently described what the risk factors are for varicose veins. Now, I have many patients that walk through the door, and my colleague, Dr. Azhar, who is listening right now, would love to know what we would do for these patients to help them.
Now, as you mentioned, even before I started on varicose veins, the funding and everything that's been going
yes,
recently.
I know. Yes.
So that has limited what we can do. However, my understanding is that as far as the funding works, if a patient has a complication from varicose veins, then they qualify for treatment. Am I correct in saying that?
That is correct, after filling out a 15-page form.
Which is correct. You have to justify that they've had a problem. But if they've had a problem, then they qualify for treatment. Now, problems. So we just need to briefly describe what problems can varicose veins cause.
Sure.
Or in a more broader term, venous insufficiency.
Sure.
Same thing. Now, a lot of people don't like varicose veins and they want them gone for a cosmetic reason. That is something obviously which is not causing a problem, that's a cosmetic thing. But other than that, varicose veins can cause pretty drastic effects, like some people get ulcerations on the leg that don't heal up. Some people get swelling of the leg, which is difficult to control. They get thickening of the skin, a condition which we know as lymphodermatosclerosis. They get pigmentation of the skin, and these are complications. Some people, because the veins are so big and dilated, that they knock a vein and it starts bleeding horrendously.
Oh, okay.
So the bleeding varicose veins. Some people get infection of the veins called phlebitis.
Right.
So these are things that if a patient has had any of these, then they qualify for treatment for varicose veins.
Okay, okay.
So I think your question was how do we manage them?
Yes, so, I mean, Dr. Azhar Chaudhry has just actually slipped in. We'll refer all of our patients to Mr. Qureshi, which we will do. And his practice is one of the largest that we have in Peterborough as well, without going into too much detail.
Okay.
Yeah.
Well,
what would we do for them?
Okay. Now, when a patient presents with varicose veins and they've had a complication of veins, the first thing to determine is it just the superficial veins that are problematic? Are the deep veins okay? And secondly, is the varicose vein due to another cause? What you don't want is someone to have another problem in the pelvis causing increased pressure on the veins, causing varicose veins.
Sure.
We treat the veins, but we don't treat the underlying cause. So it's very important to determine what the cause of the varicose veins is.
Yeah.
We need to assess whether the deep veins are patent or not, because if the deep veins are blocked, then the deep veins are not taking any blood up. Therefore, to compensate, the superficial veins are now bigger, taking blood up. So you don't want to take them away either. Otherwise, there'll be no venous drainage.
Sure.
So management-wise, once we've excluded all possible causes and it's a varicose veins which can be treated, there are two techniques to treat varicose veins interventionally, and the third one is conservative management. So the first thing which patients we should assess for is, are they suitable for endovenous treatment? Okay. Now, endovenous treatment is a relatively new, I'm not saying it's very new, it's been around for a few years now, but it's relatively new, as in last 10, 15 years it's been more popular, in which a procedure is done whereby under ultrasound guidance, a wire is there's a bit of local anesthetic given around the vein, a cannula is put into a vein, then a wire is put into a vein, and then the vein essentially, after giving anesthetic, is heated using either laser or radiofrequency ablation. Wow. And what that does is it damages the inside of the vein, so the vein then collapses and closes. Yeah. And as a result, the vein does not take any more blood in it. Therefore, the vein is out of circulation and blood doesn't pool up with blood. So that's one way of treating them, which is endovenous, and that's how majority of veins are done now. Okay. Sometimes veins cannot have endovenous treatment because they need to be of a specific size, of a specific shape, etc., etc. Try injecting veins with foam, something called foam sclerotherapy. Yes. And if even that's not suitable, then the traditional treatment of varicose veins, which is open surgery, is still done. Not as frequently as it was 10 years ago, but that is still an option. And some people want that to be done. Okay. So if a patient has had a problem with varicose veins, these are the ways forward. If a patient, for whatever reason, cannot have an intervention, is unable to undergo a procedure, or doesn't want it, provided the arterial circulation is good, you can give them compression stockings. Compression stockings tighten the leg, prevent the swelling in the leg, get the venous pressure. But it's very, very important they must have good arterial flow to the foot, because if they've got compromised arteries not providing enough blood, and we put compression on that, then whatever little blood they're getting, they won't even get that. So as well as veins, they're going to get gangrene of their foot as well due to arterial disease. Right. Okay. Okay. So with regards to a GP approach, so you've got sort of varicose veins that don't necessarily have ulceration, bleeding, venous eczema. What would you advise us to say to those patients who are still suffering from a degree of pain but don't really meet the threshold for referral? How could we help those patients, please? Again, I think, correct me if I'm wrong, but different trusts have different policies, and pain, I think, is one of the criteria which fulfills treatment. I'm not sure how it works in Peterborough, but it may be wrong. However, other than intervention, the main thing is compression then, and limb elevation. Okay. Whenever a patient is sitting down, they should keep their leg elevated. Okay. That will eliminate the effect of gravity and promote more flow of fluid from the foot towards the heart. And that will help with swelling, because patients with varicose veins, they usually say, we're okay when we get up out of bed in the morning, but as the day goes on, leg starts aching, leg starts swelling. So elevation, compression, and try to prevent standing still for a prolonged period of time. Even if you have to stand still in one spot, exercise your foot up and down, move your calf muscles, promote that blood to flow back towards the heart. These are the conservative things that are possible. So how many hours would a patient need to wear those compression stockings for during the day, Mr. Qureshi? Ideally, there is no fixed time limit. You need to wear them for this hour, this hour. What we tend to say is wear them during the day, take them off at night time when you're going to bed. Right. Okay. That's fair enough. That's good, because I get asked that question quite a lot, you see. How many hours do I need to? And I sort of think, okay, let me just think about this. But I do sort of give information to patients. Now, we've got some questions that have come here. It is a Shami from Peterborough. I have had varicose veins for a while. I've also had ulcers. My GP has told me that they are not going to refer me on the NHS. Why?
Okay, so we've spoken about this. And I think somebody's going to get into trouble somewhere over here in Peterborough.
Having ulcerations qualifies treatment.
Okay. Okay.
Unless, I mean, I don't know the ins and outs of this gentleman's case, but there may be a situation where the patient may have a deep venous problem,
Sure.
may have deep venous occlusion, and these veins may be the sole way of getting blood. Or the other thing is, their superficial veins may be normal. It may be deep venous incompetence that's causing the ulceration.
Okay.
And if it is deep venous incompetence, not the superficial veins, then I'm afraid there is no surgical option there. Deep venous incompetence you can't do much about.
Sure.
However, I do not know which kind of varicose vein the gentleman has and why the GP has said that. There must be a reason. But that's all I can say, that if it's superficial varicosities with venous incompetence giving rise to ulcers, I think that qualifies for treatment. Would you agree, Dr. Shabina?
Yes, absolutely. I think that it would. I would fill that form out for you if you were my patient. Let's put it that way. So we've got to think in the best interest of the patient.
Okay.
Yeah, absolutely. I've got another question here from a sister Fatma. Does obesity cause varicose veins?
Does obesity cause varicose veins? Obesity, I can't say obesity causes varicose veins. However, obesity can precipitate it or make the condition worse.
Sure.
Yes, as well as other things. The other issue with obesity, as has been mentioned, is that criteria you were talking about for varicose vein treatment. There is a criteria on there for BMI as well, isn't there?
Yes, there is. There is a criteria.
I think 30.
Okay.
Okay?
Yeah.
Because treating varicose veins surgically or interventionally does carry a risk.
Okay.
There is a small risk of DVTs, which is increased with obesity. So ideally, BMI of around 30 is acceptable. As it goes higher than that, the risks increase. So yes, obesity can predispose, can make it worse. Varicose veins, yes.
Okay. So I've got
there's a direct correlation though.
Okay, fair enough. I'm going to take Dr. Azur Chaudhry's, because we're coming up to finishing the show, his question, or is it a comment? He says, should we do Doppler routinely before advising compression stockings, or if the feet pulses are okay, we can safely prescribe them? So he's asking, should we do Doppler studies routinely?
If the pulses are okay in the feet, then there's no reason to do Doppler tests.
Okay.
Again, you could do that because doing a Doppler test, people do ABPIs as well.
Okay.
The point is that ABPI is also a very good thing, but sometimes in diabetic patients that can be a bit unreliable due to calcification of blood vessels.
Okay.
So bottom line is, if pulses are palpable, it's fine, you can give them.
Brilliant. That's wonderful. We have had such a fantastic show. I mean, we've gained so much. I've had, at any one time, 12 to 8 people watching at the same time. So it's been wonderful, Mr. Qureshi, having you on board. And I'm indeed going to have you on board again because this has been such a wonderful show. We've had a lot of engagement because of your input. And I know that you do. Do you have your own YouTube channel as well?
Yes, it's called Vascular Tutorials.
Right. Is this for the public or is it for...
No, these tutorials are for the general public who do not have a background in medicine.
Okay.
Just to try and educate them about common vascular problems.
I think that I'd like to signpost a lot of my listeners to that. So it'd be wonderful, listeners, if you could listen to some of the wonderful talks. You've kept us very engaged. You've been very lively, I must say. And it's been an absolute pleasure to host you. It really has been. And indeed, I will be, for my own learning as well, be listening to a lot of your shows that you have. So what was the name of it again? Vascular?
Tutorials.
So Vascular Tutorials on YouTube. Mr. Qureshi delivers these talks. How many have you done so far?
At the moment, there are 3 on there. I only started 3 weeks ago.
Oh, that was when I caught you.
That's when you caught me. Yeah, you caught me after my very first video, actually.
Okay.
I was initially doing them in Urdu and putting subtitles on.
Okay.
But then people said to me, it's difficult to follow subtitles. So then I said, okay, I'll make them Urdu and English as well. So I should be doing one this weekend.
Okay.
And then see how much time I get, and then inshallah I'll try to get one across this weekend.
Brilliant. Vascular tutorials, listeners. And thank you very much, Mr. Qureshi. Indeed, we will be gaining your advice very soon, and we'll be gaining your time once again. So thank you from myself and from Salaam Radio and Inspire FM.
Thank you very much.
Have a good evening.
Thank you.
So that was Mr. Qureshi, Mr. Khalid Qureshi, a vascular surgeon in Doncaster. And what an amazing show that was. Honestly, it was wonderful listening about the different, treatments and how vascular problems can progress and why we need to worry about it. And just like this week, hopefully next week, I will be back with another show. It's Dr. Shabina Asad-Qayyum for the Body Health and Mind Show on Salaam Radio and Inspire FM. Don't miss it. Same time, same place. Assalamu alaikum.